Mind Your Hormones, sponsored by the Laura W. Bush Institute for Women's Health. I'm Connie Tyne, Executive Director. We're so glad you joined us today, and we're particularly glad that Dr. Teresa Baker could find time to let us interview her this morning about hormones, a very critical topic for most of us. And I will just tell those who are watching that if you have questions as we're going through the interview, please use the chat feature at the bottom of the screen, and we'll try to get to your questions toward the end of our hour. But first, I want to introduce officially Dr. Teresa Baker. She is a graduate of UT Southwestern Medical Center and completed a residency training at Parkland Memorial Hospital in Dallas. She's board certified and a fellow of the American College of Obstetrics and Gynecology. Dr. Baker combines the private practice with academic medicine. She's a professor and regional chair in the Department of OBGYN at Texas Tech University Health Sciences Center in Amarillo. She also holds the Rush Endowed Chair in Women's Health and Oncology and is the director of the residency programs. Dr. Baker's medical focus includes cervical cancer, postpartum depression, and promoting preventive medicine for women. She works very closely with Dr. Tom Hale as co-director of the Infant Risk Center and also Mommy Meds. And I know lots of the people who tuned in today have already met you in one way or another through all the many times that you've spoken for us around Texas. And then of course with your work with the Infant Risk Center. We're so happy you found time to be with us. I understand you delivered a baby this morning before 6 a.m.
Yeah, I was worried about how I was going to make all this work, but as things worked out, we had a healthy baby boy at 5:30 this morning, and here I am.
That is remarkable. So we'll thank all the powers that be that
That's right.
A fresh baby this morning and didn't interfere with our schedule. So thank you, Dr. Baker. So let's start at the very beginning. Probably the first question most women ask their doctor: how do I prevent a pregnancy? Tell me what's the best kind of birth control, or what are my options, and are they safe?
So a few things about birth control that some people don't know is that there is no perfect birth control. I mean, let's just all agree that we haven't come up with the perfect birth control. And birth control has side effects. There are two major groups of birth controls. One is combination birth control, which has estrogen and progesterone in it. And then one group is progesterone only birth controls. There are non-hormonal birth controls that are less commonly used. People tend to like the combination birth controls, which are the pill, the patch, the vaginal ring, because they make their periods very regular and because they control things like acne. But when you add the estrogen, you do tend to decrease libido. So if you're having trouble with libido, that might be one thing to look at, whether you're on estrogen or not. The progesterone only family is very popular in younger women that are really looking for the contraceptive benefit, because you don't have to remember very often. The shot, the IUD, and the implant are progesterone only. And those things you only have to remember every 3 months, every 3 years, or every 3 to 5 years. And their failure rates are much lower for unintended pregnancy. However, you don't get the benefit of the estrogen. So things like acne, you're not protected from.
Oh dear. Now, all of these are fairly safe, and they're not going to affect our fertility when we are ready to have a baby. Is that correct?
Right. I get this question all the time from young women who come in with their mothers. If we start her on birth control when she's 16 or 17 years old, am I going to affect her future fertility? And the answer is, if anything, it's going to be protective, because what happens is, in an emergent situation, let's say a young woman comes in with acute belly pain to the ER, and they do an ultrasound and they see that maybe she's ruptured an ovarian cyst. Well, if that pain's bad enough, what we're going to do is we're going to go to the OR, and we're going to make sure that that cyst isn't bleeding, or that there's not something wrong inside of her abdomen. Every time we operate, we increase adhesive disease in her abdomen, and we also increase the risk that somebody's going to take out an ovary, and that's not going to be what we want to do for a benign condition most of the time. So the more I am not involved in her care in the OR, the better. So if she's having recurrent, ovarian cysts or pain, the key is to kind of quieten the system down until later in life when she wants to have children, and then we can take her off of birth control and face those issues then.
Okay, well, let's do that. Let's go to step 2. We've taken her off birth control. She's ready. She wants a baby, but it's not happening for some reason. So now we're back in your office going, what's wrong with me?
Right. So one of the things people should understand is that return to fertility is different on different kind of hormonal birth controls. So off of the pills, it's usually an average of 3 months, but sometimes after getting even one injection of the Depo-Provera shot, some women can have delayed ovulation for up to 18 months. So depending on which contraceptive you chose, return to fertility is different. But once you do start having normal cyclic menses and you're trying, which means you're having timed intercourse, you're really trying to hit that ovulation window, then, it usually at about a year, if everything is perfect with him and everything is perfect with her and they're having timed intercourse, it can take a normal couple up to a year to achieve a pregnancy, which we're not living in a world that is very patient and that sometimes feels like an eternity, especially for let's say women that have put off childbearing. They've had a career and then they get married or decide to have children at 30, 37, 38 years old. Well, waiting a year seems like an eternity and it might not even be the right decision. So depending on the circumstance, your age, or what the history is, you might want to seek care earlier, but it can take more time than people are willing to give it.
Well, is there anything that they can do personally to try to improve their odds to help them be better receptacles for this new life?
So I really believe that every woman that is of childbearing age should be on folic acid. And you can get that in a prenatal vitamin. You can get it just over the counter in folic acid because 50% of pregnancies still today are unplanned. And that neural tube closes at 4 weeks of gestation, most of the time before a woman even knows she's pregnant. So I really believe that we should all be on folic acid for that reason. And then other things, you want to come into the pregnancy at your healthiest, because what we know now is that you are setting the tone for that baby's whole life, for a lot of different things, hypertensive disease and diabetes and weight control and things like that. So you need to come into that pregnancy at your prime. So that means, weight management, that means exercise, that means decreasing alcohol intake, absolutely avoiding tobacco. Tobacco is one of the easy ones when someone comes in infertile, because we know tobacco affects both male and female fertility. So if anybody's using tobacco products, that's one of the low-hanging things that we can ask them to try to modify.
Well, I love that there's finally something that the men need to change.
Yes,
it
indeed.
Seems like the responsibility always falls on the women. So let's get those guys. Let's get those guys shaped up.
It's funny you say that, because up to a third of all infertility cases really are male factor. And women tend to blame themselves and look inward, but honestly, a third of the time it is the male. So we want that couple to come in together for infertility evaluations, and we want to talk to them. What you have to know about infertility is that women are born with all the eggs that they will ever have in all their life. So everything we do along the way, makes an impact on our future fertility. Men are different. They make new spermatozoa every 120 days. So if they have, let's say they've had an exposure at work, or, they've had a virus that had a really high temperature, that may knock down their fertility for a while, but it will regenerate. So there are a lot of things that we can do to help both sides of that. I have to say, infertility is one of the most challenging things for a couple to go through. It can be extremely difficult on relationships, on both men and women, but we've got to find a way that the blame thing goes away and that we're in it together and trying to work through the issues.
I see what you mean, because I know the women usually feel like it's their issue, their problem.
Right.
So how long would you wait before you actually counseled people to consider IVF or infertility treatments?
So There are lots of steps along the way, but it really probably depends on the age of the female to a great degree, and whether or not she's ovulating. And that's an easy thing to figure out. You can go to the grocery store and buy LH ovulation kits and find out if you're ovulatory most of the time. If you're ovulating, then it can take a while. We wouldn't want someone that was 39, 40 years old to wait a year, because we're running out of time and her fertility is going to decrease rapidly. We wouldn't want someone with known, a history of some gynecologic issues, maybe, had a ruptured ectopic or something like that. Those individuals should not wait. They should come see us early. But if you're 25 and you've just gotten married and you've just come off of birth control, most of the time, nobody's going to be very aggressive until it's been about a year.
Okay, that's good to know. So we finally get pregnant and now we lose some. I mean, it seems like so very many people I know have miscarriages. It seems vastly more common now than when I was having my children. But what I'm reading is that we just are knowing so much earlier and sooner that maybe there were always this many pregnancy losses.
I agree with that. I do think that home pregnancy tests have gotten much more sensitive. So, you get a positive on the second day that you miss your period. That may or may not be a good pregnancy. We think up to maybe even 1 in 3 pregnancies end in a loss. And that is not, it is 99% of those are genetic abnormalities, but that is not indicative that there's a genetic abnormality with either the mother or the babe or the father. When you think about all the steps that have to go just right to form this perfect little human, it's not hard for you to imagine that a mistake is made pretty frequently in the coding of the DNA. So, a lot of those are genetic abnormalities, and we often don't work that up, and that's hard for women to hear, but it's just not cost effective or really have any utility in your future fertility or anything we're going to tell you in the future. So oftentimes we just need to focus on working through the grief and trying to understand the things that we can modify, like medicines that you're on, or weight, diabetes, hypertension, things like that. I do actually think that it's probably always been this common. It's just that women tend to hide this. They have an early loss and they just go see their doctor and go back to work the next day, and they don't want to talk about it. And so maybe 2 people sitting in your office have had miscarriages, but they just never talked about it because it's painful. And I think this is one of the things that women tend to hide, one of the griefs that women tend to hide when maybe they need to reach out for some counseling.
Right. And so when would you actually recommend genetic testing?
If a woman has had, the recommendation is 3 first trimester losses, which would be less than 13 weeks. If you've had more than 3 first trimester losses, it's time to do a workup. Any second trimester loss deserves a workup. Any term loss deserves a workup. And then anything in someone's family history. So if they have a family history of recurrent pregnancy loss and maybe there's a genetic abnormality, we don't have to wait 3 pregnancy losses to work that up. We just need to take a thorough history and understand what's in both sides of the family, what we're dealing with genetically.
So when you do suspect or know that there's a potential of a genetic thing, do you do testing? Do you test that fetus early on for its genetic?
There are lots of new advancing technologies called non-invasive prenatal testing that we can do as early as 11 weeks. And that's just a blood draw on the mother that picks up cell-free DNA from the fetus. And that has advanced testing a lot. In losses, there's something called microarray that gives us a very in-depth look at the DNA of the loss of the fetus and tells us if there's a genetic issue that might be modifiable. And then often we go to the parent's DNA. So we get a karyotype on both mother and father and try to look to see if there's issues.
I'm sure that's really helpful. But I can understand, I bet you often do recommend counseling for moms and for couples. because
Yes,
it,
this
it
is.
gets the blame. It gets to be kind of such a guilt trip.
Oh, it is. And I mean, I'll hear couples say it is affected their sex life because they're afraid to get pregnant again for fear that they're going to go back down this sad road again, or that, it's so hard on couples. Both infertility and loss is incredibly difficult on couples. And I would really recommend couples therapy so that everybody kind of stays on the same page, that there isn't any blame. And usually it's self-blame. Usually the person that has the issue it's all internalized and they don't want to talk about it, but that their partner is usually, begging to be a part of it, and to get a third person in there that can mediate that conversation is really helpful.
That sounds like great advice. Okay, now let's have a fresh baby. That woman this morning has a
Yes.
brand new baby boy,
Yes.
and she's going to be going through. I can imagine what kind of a hormone storm she must be going through after all those hormones to try to keep the baby where it's supposed to be, and now all of a sudden it's gone. Oh my gosh! And let's face it, some babies are better than others. I don't mean better. Some are easier, is what I should say. Some are, just peaceful and love to sleep, and others really are fussy, and that can change how you feel.
That immediate postpartum period is one of the most vulnerable times of a woman's life. First of all, she may have hit fatigue like she's never seen it before. Some women have to labor for a day and a half, 2 days, and then they have a baby. We put them to work for 2.5 hours. Then we hand them a baby and ask them to nurse that baby, and she doesn't know what she's doing, and the baby's screaming. It is an emotional roller coaster for many women, and the concept that the movies show that, they have the baby and then there's this peaceful moment it's crazy, because that's rarely the case. It is one of the most life-affirming moments of my life. Obviously, I love it, but it is a battle sometimes. And, she's been through a war when we first hand her that baby. And then the nursing thing, I'm a co-director of the infant risk. I couldn't be more positive about nursing, but it is difficult at times. And again, a lot of anxiety and self-doubt in a mother, and especially when it doesn't go right. We all know how good nursing is for IQ points, for decreasing leukemias and, long-term infection rates. And for mom, it decreases breast cancer rates and ovarian cancer. There's all this good to breastfeeding, but it is not, natural, or it is a learning process for both mom and baby. And just like you said, some of the colic issues, babies feed differently, and it can be such a source of emotional distress for young moms. I really think this is one of those times that we as colleagues and friends and mothers and sisters need to wrap our arms around these young moms and do anything we can to support them, because I have a colleague who was 36 when she had her first baby, and she works with me in the Infant Risk Center. And she said, I've never felt that insecure in my life. And she's got an advanced degree. You think you should be able to handle it. It doesn't help. It maybe makes it worse. I'm not sure.
So I know I should have mentioned in my introduction that you are a mother of 4.
Yes.
So you know what you're talking about. Did you find that your experience has changed quite a bit? I mean, were the children was there any predictability at all, or did you have a fairly different experience in between children?
Well, the one thing I can tell you is that having children made me a different doctor. It made me a much different doctor, because, a moment when you can't feel the baby move, or a moment when you can't get the baby to calm down, or, all these things that we get phone calls about. Once I lived through that, I think I better understood that fear. But no, every child is different. I think they're different in utero. They feed different. Everything about them is different. And I think sometimes when I watch these young moms, sometimes, and I don't mean to be judgmental, I just want to throw this out there, that sometimes we are hardest on each other as women, especially in the workplace. We've been picking up slack for them for 6 or 8 weeks, and we think they're going to come back and, do exactly what they were doing. You've got to take yourself back to that moment and realize they're not sleeping. They're it's just such a difficult time in women's lives. And I think anything we can do to support them and to support their nursing goals and to support their emotional health is really something we need to embrace.
I agree. And in my experience, people don't reach out as you might expect them to. So it's almost best to say, hey, how about if I spend the night tomorrow night and give you a night off, or just bring a little dinner to the doorstep, or order fresh food or something to be delivered. I mean, just don't wait to be asked, I guess, is what I'd say.
Absolutely. And especially during the pandemic, we've seen numbers of postpartum depression and things like that just shoot through the roof, because when you think about all the things you do all the things you do to prepare for a baby shower, christening, all the cultural things, then to ask someone to get up every 2 to 3 hours for days on end is a fatigue that laughs in the face of caffeine. I mean, there's just nothing that you can do to prepare a woman for that. And once they get that fatigued, I really believe that's when a lot of the emotions play in, because their hormones are just going all over the place, mostly down to support the nursing. And, the stress, add any kind of bad outcome, like if she's had a rough time during the pregnancy, or if the baby's in the NICU, anything like that, and you just amplify the problems of postpartum depression, which is really difficult.
That makes me think of a common problem that we might want to discuss, and that is having your spouse help. We want them to help. We need them to help. But a lot of times they don't help us. They don't do things like we do them. So pretty soon you're afraid to have them help.
Mm-hmm. It is true. And I often tell spouses when they do come to prenatal visits, first of all, I tell them, when your partner has a child and is going through this, she may be the last person to recognize that she's actually depressed. She may be the last person to realize that maybe things have gotten too far gone, that maybe she's can't sleep, can't turn that ruminating thought that something bad's going to happen to the baby off. I really encourage that partner to be a part of the decision making about that they need to call me and get me involved. And yes, you're right. We as young moms don't want to delegate anything. We do it perfect, and that's the way it should be done. But it's hard for partners. I mean, what can they do to support us? So, that is just like infertility is hard on relationships, new babies are really hard on relationships, and nobody's having sex, nobody's sleeping, everybody's stressed to the nth degree. It's just such a difficult time for a relationship. And that's the point where I'm supposed to come in and help, but I can't get to her if she doesn't tell me what's going on.
That is so true. And I remember when I went to visit my son, when he and his wife had a new baby, and I would watch him and I would think, oh no, that's really not the right way to do things. And, I was reminded of there's good and then there's good enough.
That's right.
And, he was having a fine time. So the baby didn't know the difference. And so I just had to be quiet. And I think his sweet wife had to be quiet too. But anyway, they made it all's well.
Counts.
Yeah, they're making it just fine. Okay, so now we've got our babies, and now we're in a new phase of life, and we've decided that we don't want to have any more children. So the question is, do we go back to birth control pills or birth control patch or the IUDs or things like that, or do we look seriously at options for sterilization?
So this is always a really interesting conversation. What you really need to understand is sterilization by tubal ligation is not perfect either. The failure rate of tubal ligation depends on how old you are, and it may be as low as 1 in 200 in your 20s, which is a higher failure rate than some of us would like to look at. The failure rate of a progesterone-only IUD is 1 in 400. So what many people don't understand is the IUD is probably more protective than the tubal ligation. The failure rate for a vasectomy is about 1 in 600. So it's the best of the best. So, you know, there's a lot of things to consider. To do a tubal ligation is a surgery on a mom, and all surgeries have risks. So risk benefit to talk about, whereas placing a progesterone IUD is a clinic procedure and the risk is less. There are other things to consider, you know, a family history of breast or ovarian cancer. We need to talk about whether those tubes should stay where they are, whether those ovaries should stay where they are. We need to talk about if there's sexual function problems. We need to talk about bleeding patterns. So a lot of women will say, oh, I had my tubal ligation and then my periods were awful. Well, what we know now is that your period isn't awful because of the tubal ligation. Your period is awful because when you started birth control at 20, you were having a pretty normal period. Then you were on birth control for 10 years. Then you had children for about 7 years. So you're 17 years older than you were when you last had a normal menstrual cycle. And our periods change with time, and they don't usually get better with time. They usually get heavier and crampier as time goes. So you may just be seeing your actual period now. But again, there are lots of ways to control quality of life issues with hormones that don't require surgery.
So I remember once being told after I'd gone back on birth control, after my kids, you know, had all the kids I wanted, my doctor said, time's up. You can't stay on birth control, you know, all the way to menopause. But that was the old-fashioned kind of birth control. So I'm assuming now you don't have to make that decision quite as quickly.
Right. So you're absolutely right. We have birth control has evolved, or contraception has evolved, and now we use a much lower dose of estrogen. For instance, you know, older pills were sometimes 35 micrograms of estrogen or higher, whereas now we even have a 10 microgram estrogen pill. So the lower you bring that estrogen dose, the less risk of things like stroke and DVT, the really scary things that people are afraid of with estrogen therapy. And I guess I would challenge that concept that you couldn't stay on a combination birth control in your 40s. We have a lot of women that are very happy on combination birth control for both cycle regulation and for contraception. I mean, imagine having an unplanned pregnancy at 47 years old. That would be a game changer. So, you know, I think that we have to be reasonable. And if a woman has been on birth control for combination birth control for a long time and gone through pregnancies, then she subselected herself basically out of that group that's going to have a blood clot on a really low birth control pill. So I think that would be something very individualized. You definitely need to talk to your doctor, but you need to go in with the information that you're happy on the birth control pill, and what would make them want you to come off of it are things that would increase risk of stroke and blood clot, which would be like strong family history of cardiovascular disease, DVTs, hypertension, smoking. Those types of things would put migraines with aura. Those kind of are like, I wonder if we should stay on this. But for a normal, healthy woman, I think she can stay on a low dose combination birth control as long as she's happy.
I bet that's good news to a lot of people. That's news I would have liked to have heard a long time ago.
Yes.
So when we're talking about hysterectomy, I have to say a lot of older women have had hysterectomies. In fact, it seems like almost everyone I know who's past 60 has had a hysterectomy, and I know that's a little more controversial now. And then there's the question of, do you take everything, or do you just take the uterus?
So the average woman goes through menopause at about the age of 50. It's best predicted by when her mother went through menopause, and then altered a little bit by some other things. But most of the time when you ask someone when their mother went through menopause, they say, I don't know, she had a hysterectomy when she was 40 years old. Right. But what we know now is the hysterectomy numbers are really dropping significantly. I mean, it's hard to find enough hysterectomies to train residents. And the reason is the huge advances in progesterone IUDs and also endometrial ablations and some other conservative measures that we can take to control the bleeding or the quality of life issues that led to those hysterectomies.
That's
And
good news.
really, we have good evidence now that those women that retain their ovaries and, throughout menopause and never have them removed live longer. And there's a lot of benefit to retaining ovaries. Maybe bone health is one. Lots of aging things that we've shown that retaining your ovaries is really of benefit to you unless you have a reason to have them removed, like a cancer risk or things like that.
That sounds really helpful. And I know that's encouraging to a lot of people. Okay, let's talk a little more. Let's see, did we already do that? Oh yeah, what about someone who ends up having some sort of hysterectomy or something when they're in their 30s or 40s, either because of endometriosis or cancer or something like that? Is there anything they can do to slow down that whole menopause domino chain?
I think most of us would think anybody under 40 that's gone through surgical menopause should have hormone replacement therapy. Probably, I would even say that's under 50, to be honest with you, because we know women are do better if estrogen is present. And for all those reasons we've already listed, but the big ones are really bone health. If you fracture a hip, there's a 50% mortality within a year. So anything we can do to help support her bone health is going to be good. And then other things like, there's a lot of controversy about breast cancer risk. If you have one of the genetic predispositions, obviously that's going to be a very long discussion, but without it, maybe there's some benefit to having your ovaries, but also the quality of life issues. I mean, if you have hot flashes and you're not sleeping and you're irritable and that ruins your marriage, I mean, what have we done good for you? So we have to talk about quality of life at the same time we talk about risk and benefit of surgeries. And that's a very personal decision that's going to take an extensive conversation with you and your doctor. But there's more to it than just, let's take your ovaries out. There's a 1 in 60 chance you'll get ovarian cancer. Those days are gone. We need to talk about a lot more than that.
So what I hear you say is if a woman doesn't have, if she does have some sort of hysterectomy at an early age, you will start her on some hormone replacement therapy.
Unless absolutely contraindicated. And that's very infrequent. I totally agree with that.
That's really good news, I think, for a lot of women. Okay. We've got a lot of questions pouring in, so I'm going to try to get through ours first.
Okay.
All right. So this is a great one. Do you ever have women come into your office and say, I'm sad, mad, hot, and I haven't gotten a decent night's sleep in 2 years?
Yes, indeed. So as you approach menopause and your estradiol levels drop, usually what happens is you start having hot flashes. And that turns into night sweats that wake you up at 4:30, and then you can't go back to sleep. And then you start getting irritable, and then, the vaginal dryness, so that sex is uncomfortable. And that all leads to a really, really not happy woman. And so they come in and see me, and again, we're going to talk about risk and benefits, but low levels of estrogen are not a bad thing. They're a good thing, especially when we start them younger, when we don't wait till they're 70 to start them, but maybe start them during that perimenopausal transition. And we talk about ways
supplementing. I'm sorry, you're not saying them having a low level of estrogen. You're saying supplementing with a low level of estrogen is a good thing.
That's right.
I just want to make sure everyone understood that.
And there's not a test. There's not like one test that we can do and say, oh, you're in menopause. There are some hormone levels we can draw, but it's not a moment in time. It's a transition time. And oftentimes throughout that, the lab tests don't show that you're in menopause, but you're having the symptoms. And we need to treat those symptoms when they appear. We don't have to wait for the lab abnormalities. We need to make your life easier to live when you start having those symptoms. And then we need to think about, take a real hard look at risk for stroke, risk for DVT and things like that. And the college would say lowest effective dose for the least amount of time that you need it. But more and more, the more evidence that shows up, the more we're learning that if we start you early, we leave you on a low dose and we maybe do transdermals because there's a lower risk of clot on the transdermals, and we kind of transition you slowly, that we're going to improve your quality of life without really increasing your risk terribly.
Well, I know that's going to come as good news to a lot of people. There seems to be a lot of conversation these days about testosterone pellets. And I think we were talking and you said they were big for a while and they went out of favor, but now I'm hearing about them again. And that just seems to be something that's pretty darn controversial.
So testosterone in women is controversial. And what we're really talking usually about is libido. And libido is a very difficult issue to tackle. Libido for a woman, there is a natural decline in libido as our hormones decline, and that's an aging process that is natural. If we go against that and we put a woman in a high testosterone state, we can give her a libido back. No question. We can give her some muscle back. We can do some things that would reverse some of those aging issues, but at what cost is the real issue. And the truth is, we know normal levels of testosterone for men, that's like above 200 nanograms. We don't know a normal level of testosterone for women. We know there's a range, and what is safe for women, we still haven't established yet. But as an example, men die earlier than women of cardiovascular disease because of testosterone. So if I make your testosterone in the male range, am I going to hurt your cardiovascular profile enough that I'm going to make you have your heart attack earlier? That's certainly worth a conversation. Another real controversial part about testosterone is breast cancer. Your breasts were not designed to be in a high testosterone state. And we're seeing some evidence emerge that that high testosterone is not a good thing for breast cancer risk. So it's all, again, quality of life. And I understand that libido and sexual function is very important in relationships. And I also understand that it's hard when it doesn't feel good and you don't want to have sex. It's hard to make yourself have sex. So if for a relationship you need to have some testosterone, there are FDA regulated types of testosterone. Estro test is one of them that we can talk about that aren't going to put you in a super testosterone state that might put you at risk. So I think it just takes a conversation with your doctor, individualization, and understanding what the goal is and what the risks are.
Well, it sounds like that option, you're going to have a lot more control over the amount of testosterone that you're going to get versus pellets. I mean, do you get 5 or 10, and how do you know what you're getting? So.
Absolutely. I had a woman come in the other day who was on the testosterone pellets. She's about 70. And she said, I have to tell you, I was working in the garden with my grandson and I just lost my temper with him. And I was out of the norm for me, and it scared me. And I said, well, let's just check. And I obviously didn't put the pellets in. That's not my cup of tea. And we checked her testosterone and it was 2 times male level. And so that's roid rage. And that's dangerous. That's a dangerous testosterone level for her. So we've got to be careful that we're not sacrificing your health just to give you a libido.
For sure. I guess there are other things you can do to help women if they are uncomfortable or they have dryness or they have other reasons why it may be unpleasant.
Right. You just mentioned probably the most effective thing. If it's just not painful, most women aren't opposed to it. So, vaginal estrogen cream is easy. And even in breast cancer survivors that have had estrogen positive breast cancers, vaginal estrogen cream has been shown to be safe enough that we should discuss it. So, and then the other things that come into play are really about self-image. And as we age, things change. But, when stress and self-image and fatigue and pain all play in, it's not just one thing. When a woman says my libido is just gone, it's not just one thing. It's not an easy fix. I really encourage you to talk and make a physician's appointment and talk to somebody who's willing to talk through all the issues and not just throw a medicine at it that's maybe controversial.
That sounds like really great advice. Well, you know, a lot of what we've talked about today has been the stress and strain on our emotional state. And so I just ask you to address for a sec, you know, mental health issues. And are there times in women's life that we have more that, you know, when do women really come to you and say, I'm in trouble or I need help?
So we've already talked about one time, and that's that postpartum period. I really think that's a critical time to help. But the other time is kind of the time when you're going through menopause, because typically your hormones are changing, so your sleep patterns are changing. You've usually got stress at home. Either you've got aging parents that you're tending to, or children that are trying to launch or launching poorly, or sometimes launching well.
Failing to launch.
Or failure to launch. And then you've got stress at work. You know, that's many times a time that a woman's career is peaking. So, you know, if you add all the stress, right, that I hear this all the time, that they feel like, you know, they've climbed to the top of this mountain and they don't like the view because nothing feels good about what they're doing. And they're reviewing what they've done in their life. And, you know, it all starts to weigh on them. What I can tell you is that listening to many, many women come into my office and talk about these things, what's happened for a long, long time in their lives is they've put everybody else first. Right. They've taken care of their family. They've taken care of their parents. They've taken care of their children, but they haven't taken care of themselves in a long time. And it may be just simply giving themselves 20 minutes of, 20 minutes of a walk every day. A little cognitive behavioral therapy goes a long way. Some breath control, some thought control, just giving themselves a few minutes to just decompress and control their own emotions before they try to tackle the world is often more helpful than any prescription that we could write. And honestly, you know, there's evidence out there that says 20 minutes of exercise in the sunlight every day may outperform most SSRIs on the market, which are written for depression and anxiety. And we all know that the medicines that are for depression and anxiety have a lot of side effects that are going to hurt a lot of the things that we've talked about today.
You're right. My phone's blowing up with questions, but I have one more slide for you and then we'll get to all these other questions.
Okay.
With the quarantine, people have put off going to the doctor. They've put off all kinds of checkups and appointments. And I knew you had a chart for us. And so talk us through this about what screenings a healthy woman should be taking care of.
Right. I wish it were just the pandemic. I just walked out of the office and I hadn't seen her since she had her children, and now she's 50. And that's another common thing is we see them when they're having babies and then they don't see us again until they're in menopause. And I'd like to encourage you not to skip coming to see me for 15 years. There are some things that we should do, but I just we'll include this in your handout. Mammograms, that's such an easy thing. You start at 40 and you have a mammogram every year. If we catch it early, that's an easy thing. Cervical cancer screening, it's every 3 to 5 years if you've had normal, but the number one predictor of cervical cancer is not having had a cervical cancer screen in over 10 years. Wow. So please, thyroid, checking for diabetes, especially if you've had issues in pregnancy. What we're learning a lot now is if you had hypertension or diabetes or small babies in pregnancy or large babies in pregnancy, those are windows into your later health. And if you let hypertension go for 10 years, it's hard to undo the damage that was done. So please come see us and let us just do a simple screening exam and get on top of some of these issues before they cause damage that we can't undo.
Well, I'm even reading now that after a certain age, you can stop doing mammograms, you can stop doing going to a gynecologist altogether. And yet, I think a lot of healthy women are a little reluctant. It's not like, okay, well, now if I get breast cancer, I don't care. I think some of us really don't want to stop.
Right. The biggest time that we're talking about that now is cervical cancer screening. We used to start papping people when they were 18 and pap them every year until they died. But we don't do that anymore because now we understand cervical cancer. We understand it's related to human papillomavirus. And if you didn't get human papillomavirus as a young woman when you were sexually active, you're probably not going to get it when you're 50. So that's why we have been able to extend the time frame between cervical cancer screening. So cervical cancer is usually an issue that shows up in a young woman, and then it progresses. The mammogram issue is really interesting. I've heard lots of heated debate on this, but what the actual recommendations are that if you anticipate death within 10 years, you can stop having mammograms. So if you anticipate life within 10 years, go ahead and keep having your mammogram.
Oh my gosh. Well,
Isn't
that
that a strange recommendation?
That is a little harsh. I think I'm going to have to get a lot sicker before I decide I don't need those. Oh my gosh, that's shocking. Well, you did bring up HPV, and I know this is a moment when you would be happy to talk about the HPV vaccine because it's been expanded as an option now for people older. And I just don't think people totally realize how preventable these cancers are.
They are. HPV is the number one, like 70 to 80% of cervical, vulvar, and vaginal cancer in women. So that's easy. In men, HPV is the number one new diagnosis of head and neck cancer. We found it in rectal cancer, breast cancer, colon cancer, prostate cancer. It is a cancer-causing virus, and there is a simple vaccine series that you can get. We target the age of about 11 to 12 years old, and it's the concept that kind of like a bike helmet. You want to get them the vaccine before they become sexually active. You don't put the bike helmet on them as they're driving down the road, going 60 miles an hour. So I know it's hard for people to talk about their 12-year-old having sex, and it's not going to promote sexual activity. What it's going to do is protect them from the cancers. The other thing people don't understand is that HPV can be transmitted through a sexual contact, but it can also be transmitted through close contact, and it can be transmitted from mother to child in the vaginal vault. So, they may have only had sex with one person in their life and still have HPV because it was transmitted from their mother. And you're right, they expanded the coverage to 46 now. And the reason is because we've seen sexual functioning later. I mean, one of the biggest hotspots for STDs was a nursing home in Arizona not long ago. Thank you, Viagra. But, now that people are having sex later in their lives, why not get the HPV vaccine? And when women ask me about this, I just tell them, I don't want to think, I know you're married and you think you'll be married forever, but life happens, death happens, divorce happens. And if we have an opportunity to protect you from all these cancers, why wouldn't we do that?
Isn't that the truth? Because that's what we've asked for decades. Find a vaccine against cancer. And we finally have one.
We've got it, but it's stigmatized because it's a sexually transmitted cancer. And I think we need to forget that. We need to forget that and just take it as cancer prevention. What if you knew that all the head and neck cancer was because it was transmitted through saliva? Would that make you more accepting of the HPV vaccine? I don't know. I just think forget about it as an STD. Think about it as a cancer-causing virus and do what you would do for anybody.
That's great. Thank you so much. And I hope that sends a lot of people off to get vaccinated. Not that we haven't talked enough about vaccines lately. Okay, I'm going to get to some of these questions and we'll see how many we can get through. All right, number one, thanks for the recommendation about folic acid. Are there any other supplements that you think can be very helpful for women at various stages in life?
That is such an apropos question. Supplements, there's a $1 billion industry for supplements. And the truth is, no, the answer is no. Folic acid and a multivitamin would be my recommendation. Just a simple recommendation for all women would be a multivitamin and folic acid. Calcium and vitamin D are going to be important as you age. You hit your peak bone mass at 30, and every year after, you're going to lose bone. And especially if you've had a family history of osteoporosis or some risk factor for osteoporosis, I would recommend supplementation of calcium and vitamin D. But short of that, the entire industry for supplements is not FDA regulated, to be honest with you. You have to be careful about what you're getting, and they can be expensive. And the evidence to support them is not as robust as I would think it would be.
Okay, great. So here's another question. Is it possible to have a miscarriage when you didn't have a positive pregnancy test?
Okay, so there's two different kinds of pregnancy tests. There's a urine pregnancy test and there's a blood pregnancy test. The urine pregnancy test turns positive at 30 million international units. Not that anybody needed to know that, but the blood test goes down to 5. So you could have had a pregnancy for a day or two. It doubles about every 2 days. So you could have been barely pregnant and the urine pregnancy test not have picked it up because it was too early.
Okay, that's really great to know. Okay, should a woman be on an IUD or any kind of birth control after her husband has a vasectomy?
Okay, that depends on how badly you want to protect yourself. So again, failure rates are not perfect. They're not even perfect with vasectomy. 1 in 600 have an unintended pregnancy after a vasectomy. But what does happen is, remember I was telling you about the quality of life issues, and the reason a lot of people have hysterectomies is the bleeding. So oftentimes women are on an IUD, a progesterone IUD, even after tubal ligation, even after vasectomy, not for contraceptive benefit, but for bleeding control and cycle control and control of the other quality of life issues that make going through perimenopausal times not so fun.
Okay, this question is about hormone replacement therapy. And at what age would you think it would be reasonable if you hadn't had a hysterectomy at 30 or 40? Could a woman who's having menopausal symptoms, at what age could she begin some sort of hormone replacement therapy?
Okay, so again, we should be responding to symptoms. Right. So we wait for the symptoms. Once the symptoms are there, we need to treat the symptoms. So if all you're having is vaginal dryness, then we need to give you estrogen in your vagina, not all over your body. So, we need to we need to direct our therapy to whatever symptom you're having. And then the other question is, how long do you leave them on it? And the answer is as long as they need it. So, we have women that are 60, 70 years old that are still on very low doses of hormone replacement therapy because they just feel better. They don't have the night sweats. They sleep better. They're able to continue sexual function and they feel better. Well, they're safe. Relatively safe at that point. And it's a risk benefit decision between you and your doctor about whether you stay on it. But I have a lot of women that choose to stay on them for quality of life reasons.
So just to make sure everyone understands, these are people that have been on a low dose of hormone replacement therapy since menopause. You did not introduce hormone replacement therapy to a 60 or 65-year-old woman who had had no hormone replacement therapy in the interim period.
That's right.
Is that right?
So the Women's Health Initiative was the study that scared everybody away from hormone replacement therapy. And that was the real critique of that study, was that they had first starts way past menopausal transition and different hormones than we use today. We can use a much lower hormone. We can use transdermals. We can use micronized progesterone. There are other options than what that study presented that scared everybody from hormone.
Right. Now, this question is about the BRCA gene, and this is someone who does not know if the BRCA gene is present in her body, but has some people in her family who maybe have had breast cancer. Should she get screened for the BRCA? Is that pretty important? And should she avoid hormone replacement therapy until she knows for sure?
Okay, that is a wonderful question. And what we need to agree on is that only about 5% of breast cancers are genetically predisposed breast cancers. So they have a gene mutation that is driving that breast cancer. So that's a really low number. There are a lot of families that you can look in the pedigree and see that breast cancer obviously runs in their family, but we just have not isolated whatever that gene mutation is. We just don't know enough. What I can say to you as that woman is don't hide. What we would do if you came in to see me would be to put you in something called a Tyrer-Cuzick or a Gale model, which are computer generated models that take into account everything you've discussed: family history, personal history, age, a lot of different things. And it tells us a risk factor for your personal breast cancer risk. We use that to determine whether you're a candidate for genetic testing. And I really encourage anybody that is a candidate for genetic testing to get tested, because we can do so much better for you if we know. And I know it's frightening, and I know you think it's going to impact some decisions that are going to, affect your whole family, but we can do better for you if we know in advance. And I really encourage you not to be afraid of that testing. I think it's the best decision you can make, and then to let us help guide you through these decisions. I know lots of families that, yes, we have to tackle some difficult things, but it's better to have you here tackling those than have you die of breast cancer at 35.
It's so true. And I understand how scary that is to think you might be getting that kind of information, but it's not like they're going to find out they're going to die at a certain age. They're finding out that they're predisposed, that their risk factors are high, and then you're able to step in and mediate those risks.
That's
and maybe it is a hysterectomy. Maybe it is even, breast removal or something. But my goodness, that's a simple trade-off for peace of mind.
Absolutely. And there's lots of things we can do to preserve your fertility. Let's say you find out you have BRCA at 25 and you want to have your breasts and ovaries removed. Okay, that's fine. That's going to lower your risk. We'll talk to a reproductive endocrinologist prior to having those treatments, because there's lots of things we can do to preserve your fertility. And that technology is improving every day. So it doesn't mean you won't have children. It means you'll be here to see your children grow up.
That reminds me, we were going to talk about banking, egg banking. So suppose I'm in my early 30s and I know that I would really like someday to have a family, but I don't see it starting up anytime soon. Should I be considering freezing some eggs?
This is an emerging conversation we're having more and more now. And as I was saying, the technologies are improving. And if it's heavy on your heart and you are over or approaching 35, you should probably make a visit with a reproductive endocrinologist just to talk about options. The other group that should is anybody that's going to have to be exposed to something that could be toxic to their ovaries, be that radiation or medications, chemotherapies that could potentially be toxic to their ovaries. You want to have those conversations prior to initiating that therapy. And there's lots of reproductive endocrinologists, Dr. Kaufman, Dr. Fye in Lubbock, lots of people that could talk you through what options exist and what the success rates are of those. And that's one of the wins that we have now, because that's, you hear the C word and you just freeze. But people live a long time with cancer. There's a lot of that. That is something we really all got to change our thinking on and get the reproductive endocrinologist involved early so that we maintain the ability to have whatever family you wanted to have.
You mentioned Dr. Fye, and our last question, we can just be really quick, was about PCOS. And Dr. Fye, who runs the infertility clinic in Lubbock, has had over 1,000 healthy babies born to women with PCOS because she has been able to get them on proper diet and proper care. And so one of the questions was, what do you do if you have PCOS and your hormones are too high? How do you manage that?
That is not a quick answer, but the answer is for PCOS is typically to control symptoms. Again, so when they're young and their testosterone is higher than they want it to be, and they're having acne and hair growth and irregular periods, the answer is to put them on a birth control pill with a lot of estrogen in it, because that estrogen goes to the liver, makes their liver make something called sex hormone binding globulin, which is going to decrease the circulating testosterone and manage those symptoms. Then when they get through to the reproductive age group, we're going to probably have to use some medications that are going to help stimulate ovulation. And then as they reach menopause, it's really interesting. PCOS tends to get better as you age. And we think that's because the theca, or the stroma of the ovary, starts to make less testosterone. But oftentimes those women's periods become much more regular as they age, and they may not need as much hormonal manipulation as they age than others.
Wow. Well, we're out of time, but we've had so many people put a note in the chat. I hope you're recording this, because I'm going to have to watch it again and make notes. And so I will tell everyone that, yes, this has been recorded and it will be on our YouTube channel by tomorrow. Also, Dr. Baker is willing to share her slides. And even more generous is that she has given you, I already had her email address, but now you have her email address too. And if you do have a personal question, she is happy to take a look. And she said, don't expect an answer back this afternoon. But hopefully with her 4 children, her practice, and all the many, many jobs that she has, she'll try to get back to you as soon as she can. Thank you so much, Dr. Baker. You have taken an incredibly, in fact, complicated topic. In fact, when we were talking yesterday, you said, this is my entire career in 45 minutes.
That's right.
This is a brain dump. This is everything I've known, but you have been fabulous. And you have given us, I can't imagine that there's anyone who's watched this who hasn't learned something. And so we just thank you from the bottom of our hearts for that. And thanks so much for your time. And we would
Thank you for having me.
Thank you. Well, everyone, please watch your inbox. We are making plans for our next webinar. And I do have a fantastic female cardiologist who's going to be talking to us about women and heart disease. And we don't have a date for that yet, but we'll get it out by social media and also by email to all of you as soon as we have that date. In the meantime, go get your checkups, take your supplements, check out all of Dr. Baker's recommendations. And we just thank you all for being with us today. And thanks for a great session, Dr. Baker.
You're welcome. Have a good day.
You too.